Appreciate you joining for today. Our latest session for Global Health Corps' Shift Happens series. Today, it is called Rethinking Global Health Financing in an Era of Scarcity and Sovereignty. For those of you that don't know me or I haven't had the chance to meet, I'm Heather Anderson. I'm the CEO of Global Health Corps. And I'm so honored to be with a remarkable panel of leaders and practitioners. They are all at the forefront of figuring out how we make equitable and sustainable decisions on financing public health now and into the future. So I am so excited, and it is my pleasure to introduce our moderator, Aasit Nanavati, who is the Chief Strategy Officer at DevResults. His focus is on strengthening data-driven decision-making and impact tracking. He has managed major U.S. funding, health financing programs, supported advocacy efforts like India's national TB campaign. He serves as an adjunct professor at George Washington University. He's a member of the Council of Foreign Relations, and very importantly, he is also a Global Health Corps alum. I am now going to hand it over to him because we're so delighted to have him serve as the moderator for today's panel. He can introduce himself and our panelists. And just a quick note before we dive in, that just to say that the perspectives shared are those of our panelists as individuals and don't necessarily reflect the views of their organizations or GHC. And no doubt it's going to be a very rich discussion with all of you. So thank you again for joining. And with that, I will turn it over to you, Aasit.
Yeah, Heather, thank you. And thank you for that introduction. Really excited for everyone that's here. And thank you to Hannah and Global Health Corps to organize this and excited to have this conversation as so much has happened over the last 6 months and 7 months throughout our sector. But before we get into the conversation, I want to introduce our panelists. We'll start with Soleine Scotney. She's a health financing and systems leader with 15 years of experience strengthening primary healthcare across Asia and Africa. Kathleen McGee is a health economist and currently a PhD candidate at the London School of Hygiene and Tropical Medicine, and Christian Abraham Arriga, who is a global health professional focused on strengthening health systems and advancing UHC universal health coverage in LMIC's low to middle income countries. I'm going to let them introduce themselves in greater detail in a moment, but I wanted to set kind of the framing of this conversation. As we know, a lot has changed, particularly in the global health system landscape. While countries are going through these changes, we still see an increased need for things from pandemic response, climate-related issues that are continuing to be global threats, as well as the global burden of non-communicable diseases in nations across the world. And it's really kind of shifting how we are addressing those problems. And a core component of that shift is understanding where's the funding coming from, what can we do with that money, and how do we advocate and create kind of an industry of trust as we see so much that's happening and changing across the global health landscape. So in this conversation today, we're going to jump into these challenges. We're going to look at the opportunities in where we can work and strengthen these issues across the board. And we'll go not just into the mechanics of health financing, but we'll also go into the political economy behind it, how the decisions are made, who are the people making those decisions, and what roles do we have as people as practitioners in the field, as well as working with populations around the world to figure out what are the mechanisms that we can put into place to strengthen global health security worldwide. So I'm going to hand it over now to the panelists to introduce themselves. I'll start with Soleine. So please introduce yourself and your background, and then we can go to Kathleen and Christian, and we'll jump right in right after that.
Hi, lovely to meet everyone. Yes, hi, I'm Soleine Scotney, and I'm currently the Chief Program Officer at the Financing Alliance for Health. It's an Africa-based, Africa-focused organization that works with African ministries of health and ministries of finance to do two things. One, raise more money for health, but two, also have more health for the money. And we'll be talking about that. But before Financing Alliance, I worked for 11 years for Chai. I would say I've had the privilege in my career to work at different parts of the system. Most recently at Chai was the country director for Cambodia, but before I worked on market shaping, so working with private sector manufacturers that were manufacturing some of the life-saving products. I also worked on vaccines across the African continent, so in one of the verticals, or so that's how we call them within global health. And before Chai, I worked at the Global Fund, so more on the donor side. And then before that, I started my career at BCG in strategy consulting. I'm really excited for the conversation because I think it's a very important one. Maybe over to Kathleen.
Thanks, Soleine. Hello, everybody. I'm Kat, calling from Dakar, Senegal, and I was a Global Health Corps Fellow in 2012-2013, based in Rwanda. So today I'm a health economist and I consult largely for UNAIDS, but I'm also a part-time PhD student at the London School of Hygiene and Tropical Medicine. So my work at UNAIDS these days, I've been focusing a lot on actually recently developing guidelines on how to cost national strategic plans. That's actually a result from a review I did a few years ago where we found a lot of methodological challenges and issues. And so really like providing guidance on how to properly cost a national strategic plan, not underestimate, not overestimate, because it's really, really important, especially now, to really get a good ballpark figure and help countries also determine with the budget analysis, any financing gaps, and also what's the most cost-effective mix of different services and programs they can deliver while still focusing on equitable efforts and making sure we're reaching most vulnerable populations. I also work with communities and making sure that we know how to cost community-led responses and making sure that they stay at the forefront of all the services that we provide and that we finance them sustainably. I'll stop there and pass the mic to Christian.
Thanks, Kat. Hi, everyone. My name is Christian Abraham, and I was also a GHC fellow in the most recent years of 2023, 2024, based here in Malawi, and was placed with Chai and have continued on with Chai as well. So my current work is with the Health System Strengthening Cluster. I'm a senior associate working on a range of health financing and health workforce planning issues. Over the 2 years, majority of the work that I've supported has really been around providing support to the planning and policy department within the Ministry of Health on the financing side, trying to think about how to design sustainable financing systems and plan, budget, and track investments to really take the overarching vision laid out in its strategic plans and operationalize that and rally both donors and different departments within the ministry to use it to map and plan their priorities in a coordinated way. And then on the human resources for health side, providing support to the HR department within the ministry as well in terms of workforce designing and planning in order to just really understand what quantities of healthcare workers, what skill mix is required at different levels of care to meet the needs on the ground now and project forward as well as the needs of the population grow towards 2030 and beyond. So happy to be here to discuss today.
Yeah, thank you for kind of those introductions. It's important for me to kind of get a good understanding of where everyone is coming from. I think that's one of the values not only of our industry, but also of Global Health Corps and how we work throughout our careers in global development, global health. The diversity of experiences and the community that we do have will surely be something that we need to rely on as we go through these changes and we rebuild, really how we work, where we work, and what our priorities are. So to that, as we consider the future of health financing, the Center of Global Development estimates that cuts to U.S. funding alone will reduce the health budgets for over 35 countries by more than 10%. And 10 of those countries will have potentially over 50% reductions in their health financing budgets. And we're seeing these conversations play out in nations all over the world. So I'm curious, Christian, with foreign aid shrinking and and impacting so many different aspects of healthcare budgets, because we know healthcare is a very broad statement, a very broad sector in itself. How do low and middle income countries see the need to fill the gaps around the priorities for their own nations and the priorities for individual healthcare needs?
Yeah, thanks, Aasit. And maybe I can start by helping to paint a bit of a picture about what aid cuts look like in Malawi and the extent of that impact as well, just so we are on like the same level playing field. So in Malawi, in the last fiscal year, the US government, so USAID and CDC combined, brought a budget of about 185 million, and this comprises 27% of the funding in the health sector overall. So it's I think it's the second largest donor in Malawi. And so while not all of this funding has immediately been lost, we have mapped that at least 10% of this funding has been completely pulled at this point. So about $62 million that the government needs to think about how to reprioritize its own health budgets or get money from other donors as well to fill this immediate gap. And so that's on the financing side. But then when we think of, okay, what does this money actually look like on the ground? In terms of health workforce, for example, the way that the system is designed in Malawi was that majority of healthcare provision for those with HIV was done by cadres, healthcare workers that were fully PEPFAR funded. So about 4,000 healthcare workers that will no longer have a job in the coming months, and millions of people on HIV treatment, millions of people that might still yet be diagnosed with HIV that would have disruptions to service delivery. So this is a really large shock to the system that we're talking about, and not something that can be kind of immediately filled, especially in a place like Malawi where there is very limited fiscal space. And so I think when we think about how to fill this financing gap, a few things emerge in my mind. First is really trying to understand the scope of the impact in as detailed a way as possible. So really looking at this big gap in funding, what does that actually look like in terms of service delivery, in terms of staffing? Was it going towards commodities, et cetera? For example, in Malawi, one of the major gaps is being able to provide continuous testing. And so in order to ensure that that does not get disrupted, trying to find a way to replace the work that these parallel cadres did with what exists in the system. So using the current staff to kind of absorb this work to minimize the service disruption is one way, because parallel systems are not necessarily always created because there isn't the capacity within government to take that on, but sometimes just because the money is there and it's easier to hit your targets if you have your own separate line that you fund. And so I think trying to understand the scope, which then leads to my second point, which is around finding those efficiencies. So where possible to integrate service delivery, integrate these disruptions, trying to find ways to exist, to leverage existing staff systems, et cetera, to absorb those activities that were being taken up by donors will hopefully help to kind of mitigate impact where possible. And then, just also thinking about how sometimes integrating services and integrating activities isn't always going to mean that things are cheaper. So trying to find the most cost-efficient ways to do that. And then I think lastly is the resource mobilization piece. So I think that, in some countries, it's a bit easier to talk about increasing the fiscal space or increasing domestic resource mobilization. But in a country like Malawi, where 55 to 65% of the health budget comes from donors, where there is an extremely constrained fiscal space and majority of the existing money goes towards refinancing debt, I think it's not really something that we can be able to talk about expanding fiscal space within the short term. But there's been discussions of trying to introduce access conditions. For example, in Malawi, healthcare is completely free at public hospitals, regardless of how much money you make. But there's opportunities there to kind of leverage the people that can pay to subsidize those that can't, so that not all of the money that's going towards providing a benefits package is coming from the government. And then there's also opportunities to have those conversations, critical conversations with the donors that are still around, about how to reprioritize what they're funding to ensure that they're funding the most critical priorities within the space, and continuing to advocate where we can to ministries of finance around trying to take up more of the essential medicines and commodities onto the health budget, for example, because in Malawi, majority of that is donor finance. So just trying to think how to mitigate in the short term, but also design systems that long term will be sustainable and won't feel as much shock as we do right now.
Yeah, no, thank you for that. And I think, I wrote it down. You said shock to the system. I think that is certainly something that a lot, if not all, of the people that are on this call today kind of have felt. And I think one other thing that I think is really interesting is that this is not just, in my opinion, a financing issue alone. This is an ecosystem issue, as you've kind of walked through, that this is not just impacting the line item on an Excel sheet, but it is actual people, both from the delivery side, so the community health workers and the establishment that is really trying to support the infrastructure to create a healthier society, as well as those who need the delivery of those medicines, the delivery of those healthcare packages and things like that. And I think that's one thing that has resonated over the last few months for me, is that, this is not just a single issue where we could fill in the gap immediately with, let's say, philanthropy or private sector funds or other things. It's something that is an institutional change, and we need to rebuild the ecosystem of how we're going to deliver aid across these countries. And you've kind of laid out some of those different variables in Malawi. So my second question is, we've kind of building on that. We often hear about foreign aid and philanthropy being an opportunity to fill in some of these gaps. In the early days of the changes here in Washington, there was a number of different meetings about the role of philanthropy. It's still continuing on. I'm sure everyone has read or participated in those conversations around how philanthropy can support. But we also know that there are other options for health funding that are and can be leveraged. The World Bank has estimated that remittances alone can triple what was invested into foreign aid, and other financing, including health impact bonds or blended financing or public-private partnerships, are all different kind of opportunities that need to be explored and that are being explored today, as we look at kind of the ripple effects of the decisions that are being made at the policy level. So Kat and Soleine, I'm going to ask you, what are some of the more promising innovation in health financing that countries may not think they just don't work. And other times they do, and they transform a sector. So yeah, I'm curious to hear, how those innovative financing models or options are living up to the hype or potential rather.
The question a little bit because as Christian said, we first need to start with governments, and we need to begin with improving that fiscal space at national level, and then these other sort of innovations can come in as sort of complementary strategies, but they're not going to replace nor fix what's happening right now. And so to just first respond to how do we improve that fiscal space, Christian spoke about all sorts of different strategies. There's a few more I'd like to add too. So there's countries, not necessarily Malawi, but there are other countries that will have natural GDP growth over the next few years. Like Zimbabwe is expected to have a real GDP growth annually of 5%. That combined with reprioritization of national budgets towards healthcare can make a huge difference. And in fact, they've done a few modeling studies and they found those some of the interesting levers for certain countries in order to reduce those funding cuts and that funding gap. But it does require political commitment, and that window of opportunity is not always available, and it depends on economic context, obviously. But those are opportunities. Another one is for countries to use maybe like sin taxes, for example, on alcohol, sugar, and tobacco. Those have to be very carefully applied because they can have indirect effects against the populations we don't want to hurt the most. But they are interesting sort of strategies that have been successfully applied in some countries in Southeast Asia. And those sort of profits that are made can then be earmarked for the health sector, for example. So those are opportunities at country level. Those innovative financing schemes like remittances, for example, are interesting. Like you said, there's like about $700 billion in remittances compared to like $200 billion in development aid towards low and middle income countries. But it requires governance. It requires people to trust that if they're going to send their money rather than to their household and to their immediate family, that they trust that the government is going to use it well and that it will actually positively impact their communities. So to do that, governments have to improve on their social health insurance schemes and continue building trust with their local and expat communities so that we can actually channel all of that money and all of that opportunity towards those kind of financing schemes. But it really relies on that sort of governance and baseline of trust in a sense. And you've mentioned a few other schemes as well. There as well, it's sort of, those are interesting schemes where you have private sector join with the government, and then they will both sort of contribute and invest in a certain program for measurable health outcomes. And those are really interesting schemes. For every $1 that the government puts, they can sort of bring in other investors and have $2 or $3 put in as well. And those are interesting, and they can share risks towards those health programs. The challenge with those is that to have those sort of agreements, you need to have measurable health outcomes and sort of say, okay, we are going to purchase, X dollars per pregnancy averted, or per person tested, or per district that reduced neglected tropical diseases, for example. And they have to be really measured and short-term outcomes. That's still working within the framework of vertical disease interventions, right? And not necessarily as malleable in sector-wide transformation and sector changes that we know that we need to do on a much larger scale. I'll stop there and pass the mic to Soleine.
Thank you, Kathleen. I was going to say the same, that we should start by the why. And the why is that African governments, as all countries around the world, have committed to putting in place universal health insurance schemes by 2030. And that's incredibly challenging to do in countries where less than 10%, if I take a Sierra Leone, for instance, or a Central African Republic, of the population is working in the formal sector. Because if you think of, say, Europe, the major way that this money has been raised is through salaried contributions from the formal sector. So then how do you do this? What we've seen from the countries in which Financing Alliance is supporting is that it is allowing to push a little bit more, actually, the conversation, because there is such high-level political commitment, even at the President, Prime Minister, Ministry of Finance level, to this objective. And this is where we're often seeing that things like, indeed, sin taxes, and I'm a little bit more positive in general about sin taxes. I feel actually the evidence is that, yes, there might be an immediate effect where people feel hit, but actually the long-term benefit to the health of the populations, even the poorest one, is actually positive. Or indeed remittances. I would also mention taxes on natural resources, because a lot of the poorest countries in Africa actually do have a lot of natural resources, but it's not necessarily that the populations have been able to benefit from that. So this is sort of a good redistributive mechanism, and one to sort of hold countries to their commitments. We do see, for instance, Zambia also recently introduced just last month sin taxes on sugar and sweet beverages. And, you know, there's a lot more momentum in light of some of the Africa CDC, Bellagio communique, and a number of other landmark, actually, in the wake of the ODA cuts, a lot of thought leadership to reimagine what is necessary for countries to own their health systems. But then your second part of your question was, what is standing in the way, right? And some of it, I think Kathleen has talked about, and as well Christian, around the fiscal space. And indeed, where I would add on the debt swap piece, I think there is different, even within Africa, you can segment countries based on where is their debt burden. They're not equally indebted. Some could take on more debt, assuming that the return, that debt is well invested, or is combined with a debt buy down, which could be an incentive mechanism. And where I would say is that essentially they need to make more return on investment than the cost of the debt, if that's the case, right? Here, the best buys are primary health care. They are community health systems, which have been shown to have a 10-to-1 return. For some countries, it's not an option because they are already basically beyond everything that a multilateral wants to lend, because they're already with commercial creditors that have very high premiums. And so for them, the debt swap is a good option. And you're seeing a lot more even of the countries that we support, Kenya, Senegal, Sierra Leone, even at the very highest level, say we want to engage in the debt swap. Now, the problem is that because there's been so few debt swaps in health, at the moment, it's a very high transaction costs and several years for countries to implement one. It's also the question of how are you going to measure, right, whether this was a good investment, because you need, normally there's a few conditions for a debt swap. One is a long-term vision, which governments have set. Another one is an underinvested area, and that is definitely the case of primary and community health system, but then you need to have clear metrics. My preference, I believe that now countries have put in place strong enough data systems that we could not just tie it, and it would be an incentive to improve them further, to one outcome of health, the vertical side of it's just pick malaria, but instead choose a few tracer indicators on maternal child health and communicable diseases, for instance, that would act as the trigger under which debt is being swapped every year. Basically, if they meet these conditions, then the debt, it's an incentive essentially for them to do the right investments to ensure that money hits the front line, because then the debt will be swapped if those indicators are reached. That there's a few things that are currently being conceptualized, and I think there's more room for the debate to continue. The other thing that's missing, though, I would just mention, is capabilities, right? You asked what stands in the way. We really need to see health financing capabilities of ministries of health and Ministry of Finance be strengthened so that they can be at these level of the discussions. They can continue the public financial management reforms that they've started. And so at Financing Alliance, one of our initiatives is that we have a government health fellowship accelerator, where government staff apply with a policy reform on health financing that they want to see to fruition. And during 9 months, they are actually mentored to bring that policy reform to operationalization. And so that is an example of how to build the skills and also how to create champions that I personally am very excited about. Over.
Yeah, thank you. I think a few things resonated in those comments. I mean, at first, the political commitment is one that we're seeing an increased need for, and I kind of want to shift some of the questions remaining into, how do we create that environment with politicians and with people that are leading the charge on some of these decisions. I think secondly, as a monitoring and evaluation person myself, I've spent my entire career in M&E and data management. Having the metrics that matter is really important, and moving, from my perspective, moving the needle on M&E reports being, a static PDF document that nobody reads to something that is part of like the day-to-day culture of an organization, of government agency, of individuals, in order to make decisions rapidly, because we are seeing decreases in funding. That means there's going to be increased scrutiny on that funding, on where that money goes and what type of programs are going to be invested in. So I really appreciate kind of both of those conversations and kind of want to build on that. There have been longstanding criticisms of foreign aid and philanthropy from stakeholders throughout the years, not just over the last 6 months. We know that we've worked in it. I'm sure everyone has felt, that inner frustration with something when you're in country. I used to live in Uganda, and that feeling does exist that we can do better. And I think we want to do better, and we have to do better. But I think over the last 6 months, focusing from the US perspective, the speed at which these shifts in global health funding happened in 2025 with the decisions that were made with those in the current administration here in the United States, as well as the cuts and closures to programs led by USAID, have really felt, going back to what Christian said, a shock, real shock to the system. So I wanted to lean in on, what lessons can we draw from programs like the Global Fund or PEPFAR in their experiences on planned financial transitions from foreign aid and the impacts to health outcomes. Kat, I don't know if you wanted to jump in on that conversation.
Yeah, I'll go in very specific detail with, for example, the Global Fund, is that something that they've been pushing over the last few years is, okay, we're investing this amount of money. You domestically have to also match a certain amount and invest in this. They've been doing that for a while with varying success. Like South Africa is one where the dialogue started very, very early on. And today they're quite resilient to the current shock that's happening because they've been so invested, at least in the HIV sector, I can speak for that. They've been so invested in domestic financing and really taking the lead on that. But Global Fund has also done something where we have, and PEPFAR, have to invest in communities. So for example, making sure that communities are at the table when we're discussing national strategic plans, and not just to talk about, what action point will happen in the Gantt chart, but also talking about where the money is going to land. And that's been always a tension happening, but they've insisted that a certain amount need to be allocated to communities, and that's really important and something that's going to needs to continue to happen, because communities, usually we tend to task shift a lot over to communities and be like, all right, they can take care of it, and not sort of consider the burden, the economic burden that we're putting on communities to take on those responsibilities. And we really rely on them. And we've seen that, with Ebola outbreak, with COVID, etc. And we are going to rely on them in this new crisis. So that's another sort of lesson learned that's been really interesting, is making sure that when we're working with governments, we're not just talking national high-level sort of stakeholders discussing how the financing and where the money is going to be, all those resources are going to be allocated, but making sure that communities and representatives of vulnerable and key populations are present at the table and are given some resources to support the work that they're going to be tasked with. That's enough.
Yeah, no, that was great. And I want to kind of build on that, going more into the politics, and the global health financing is a deeply political decision based on who's paying, who's the decider, who are the beneficiaries, and it's potentially not always equitable based on a varying number of decisions that are being made. So I'm going to pepper a few questions, Christian and Soleine. I'm going to start with kind of how can financing models promote equity rather than exacerbate the disparities around financing, and are there examples that you've seen of beneficiaries successfully advocating for greater accountability, kind of building on that idea, Soleine, of having measurements and having metrics that matter? So we'll start there, and then I can go into a few other questions around the politics of decision making. But Soleine, if you'd like to get started, and then we can pass it to Christian if that works, or vice versa to you.
Maybe I'll start then. Yeah, I think it's first important to recognize the big picture that the global health architecture itself has a really troubled history. It started with basically the colonial era and military control, where the goal was not to improve the life of the population, but instead to ensure that communicable diseases would not bother the troops and wouldn't impede the order in which the colonial powers had created, had put in place. And the sad thing is that a lot of this vertical focus on eliminating diseases has persisted. Financing Alliance for Health study, a recent study actually showed that over 70% of the funding that has gone to community health workers, for instance, through external assistance, was to single disease programs, right? And this is despite the fact that as early as in 1978, governments across the world and in Africa in particular emphasized primary healthcare integrated as the foundation for health equity and the cornerstone for global health. But, whilst I'm very sad about the ODA cuts, and they do have very huge impacts for so many, we should not, to quote Churchill, let a good crisis go to waste, right? And so this is a moment where we have to imagine a better system. And we need to recognize that these imbalances of power, they were not just balances of power between sort of the North and, let's say, the Global Fund or other global health institutions giving a menu to, literally a drop down for which then the country selects which of these interventions they want to carry out. Because of the way the money was then allocated to vertical programs within ministries, vertical bank accounts, it then led to imbalances of power within ministries of health, where the vertical programs were rich, the ones that had a lot of donor funding, and then no one wanted to work on some of the other diseases that were more neglected, or, if family planning was perceived to have less donor resources, no one would want to work on those directorates, right? And the integrated departments in particular, which should have had this kind of conductor role of helping ensure that all the programs were in tune, generally had, one or two people for the whole of the ministry, whereas you'd have like 30 people at the Center for National Malaria overseeing that program specifically. So we need to change that balance of power, both between North and South, but also within country, so that the voice of the primary healthcare is not just seen as a place for delivery, which it is since a long time, but a place for governance as well, because that's where we can get communities to actually score the services that they're receiving, talk about the life journey of, like, if I come with my child, we both want to receive services at the same time. We should be actually getting health promotion because I fall in this category. I should be screened for certain things on a life course approach, not just because a donor has specifically funded one specific vertical. And so the future architecture, in your question of what should donors focus on, I think it should be basically aligning behind country term sheets of this is the country plan, and then donors are in the room and they can raise their hand and say, okay, I am investing in this plan and I'm taking this piece and you're taking this piece, and together we can achieve more together, and in particular finance the public goods that are the soft infrastructure that are less visible. And so, yes, politicians are not keen to invest in primary healthcare and health, human workforce and community health, because you cannot put your name on the building, right? But they are the fundamental building blocks of reaching the people in the village, of avoiding the next pandemic. And so this is really what I feel the future of global health needs to look like. I'll pass it over to Christian to end.
Thanks, Soleine. And yeah, I think you touched on a lot of the things that, I also wanted to emphasize. And I think maybe one thing that I will say, going back to Aasit's earlier point as well about measurement and like picking the right kinds of metrics, in a way, I think that the reason why we have prioritized lots of vertical service delivery is in part due to metrics, right? They're easier to measure. It's easier to say, we, reduced malaria transmission by this amount, or this many people are on ARVs, whereas systems investments or just, primary healthcare interventions are at the moment less easy to measure and less easy for someone to kind of, tag their name against. And so I think part of what needs to change and where we need to go to have better equity and better interest for these interventions is to measure these things better and tell a better story about why we need systems level investments. And And then I think maybe just to give an example about like what rallying behind a government plan looks like and how that plays out on the ground, because it is something that, you know, Chai does support across many countries, and in Malawi we have supported over the past like 3-4 years now. And you know, it has taken time, but in light of all that is happening now, I think it's quite a great opportunity to really think about how do we approach planning in an integrated way? How do we invest in systems? Because the disease directorates are no longer the, like, you know, very rich people that you have to like go to ask for more money or try to get them to be on the same agenda. And so there's been concrete examples both at like the district level in Malawi, where the district tries to rally donors at the district level, has implementation plans that are mapped out, that donors can come and say, okay, this is what I will spend money towards, and here's some of my funding that is going towards what aren't directly your priorities. But I think as time has gone on, more and more of the conversation has really been to try and rally everyone, both at the donor level, but even within government across the malaria department, HIV department, et cetera, to those like integrated national priorities, and letting that be the basis upon which we are driving the agenda, applying for global fund monies or, you know, other big funders instead of the other way around. And then I think in line with that, also just having transparency with budget information, finance information at the government level, sector wide, right? Not just with the specific directorate that you have signed an MOU with, but across the system, to know what money is coming in, where do duplications exist, where can we find synergies to use the limited money that is coming in a way that is kind of equitable. If there's an overemphasis on 1 or 2 districts because they're easy to get to, or, you know, they're easy to work with, like reallocating that as a government. So having that like cross-cutting body that's able to kind of balance that, I think, is really important as well.
Yeah, no, absolutely, and appreciate those comments. And I think I just want to open it up for questions and to get more from those who are listening in. And I think I kind of want to just wrap it up for me is, thank you for the discussion, but importantly, as we open it up for questions, to look at this moment as a moment of opportunity. I think, Soleine, you kind of mentioned this in your comments, that this is an opportunity to be creative around how do we rebuild and what does the new foreign aid landscape and the global health landscape is going to look like. And all of us here have a role to play in that, and it's a very important time. And it's very kind of crucial for us to kind of work together and be collaborative on that. But we can get into that, after the call as a follow-up. But I wanted to just open it up for questions. I don't know, Hannah or Heather, if you wanted to jump in from questions in the chat or additional comments.
I always have lots of questions, so I'll give everyone else a beat who's listening in. But again, encourage you to put it in the chat. So this question is for really any of you, but especially GHCers, that's sort of a big focus for us is around collective leadership, and knowing that sort of like the power of innovation and doing things differently come when you bring people from different backgrounds and expertise together. I'd be curious, Christian, you were just talking a little bit about it, what you've seen as an example at the district level, but, I'd love to hear, any other examples that you all are seeing of how folks are coming together in ways that hadn't been seen before, or perhaps coming together now differently to be able to try to solve what now is, a common challenge that we're working for together.
I don't know who wants to take that. Kathleen, should I put you on the spot?
No, I was thinking Christian would be better positioned.
Sure.
Yeah.
Oh, it looks like Soleine, I see your hand up.
If Christian wants to start, Christian, do you want to start?
You can go ahead. I'll come in after.
Great.
Okay, yeah. I mean, I think there are a few different levels where this is happening. One is in country where I have seen, I mean, I think across the countries, there's been much more effort on resource mapping, but changing also resource mapping from being the static thing that happened, 3 years after the fact for the national health accounts to something that's a lot more live, and where therefore what Christian was describing, which is we identify who are the underserved district, what are the underserved populations, maybe comparing that with the data outcomes on DHIS, like where is less testing happening, where is there higher positivity rates for TB, or that is really the marrying. Often the financial and the programmatic are completely separate in ministries, which is a massive issue, right? And so it's like, oh, it touches finance, it's for those people. I'm just doing the M&E, and that's just like completely wrong, because what you need is actually that, the two come together. And I'm seeing a little bit more of that happening at this moment, because the resources are so scarce, that there is that recognition that we all are concerned by what the use of the financing is. At the global level, there's different initiatives that are happening to try to see how funding can be more aligned. One that comes to mind for me, of course, is the Africa Frontline First, which is a fund that Financing Alliance, Last Mile Health, the Community Health Impact Coalition actually created a few years ago, and that then received quite a bit of money on C19RM because it was linked. It's a fund that funds community health workers and helps to achieve the goal that was set by the African heads of state of having 2 million community health workers on the continent, but not just having them with the 4 S's. So salaried, supplied, equipped with supportive supervision, and also smartphones, like digitally enabled. And so for this fund to be successful, what we've seen is capital stacks, right? Where there's been funding from J&J, there's been funding from School, there's been funding from Global Fund. And right now we're in the wave of the design of the next fund, which is going to be called Resilience and Sustainability Fund of AFF. And we're seeing new voices of new partners, new donors, both philanthropic and bilateral, and others that are at least interested in considering aid alignment. Because the core principle there is that, it's a matching fund where governments actually need to put skin in the game of their own resources to unlock the resources for community health.
That's great. Christian, would you like to add?
Yeah, I know we've talked a lot about, just like aligning government budgets, aligning within the like Ministry of Health, but I think that there's also lots of opportunities for like cross-sectoral collaboration and alignment to further the same PHC goals. So for example, one of the things that we support with here is trying to increase like energy access for health facilities, because it is important for primary healthcare provision to have health facilities that are well equipped, that have the power they need to provide that services to decongest the secondary and tertiary levels of care, which are currently very congested. But that in previous years was not really a conversation that would happen as much between the Ministries of Energy and Ministry of Health, but would just kind of be something that the Ministry of Health would lobby for by itself with donors to get, solar panels installed in X facility in this district. That, so I think coming into play that like coordination role in between ministries towards the same goals as well, and find those synergies in terms of the plans that the Ministry of Energy has to reach more public facilities, but then merging it with the data that the Ministry of Health has in terms of which are the places that have the highest disease burden, which are our facilities that are being underutilized, or like where the biggest community need is for primary healthcare provision, can really help to like create bigger impact at the community level as well.
Sure. Thank you. I think, just looking at the time, we did just get one question in our chat, so I did want to address that. I'll open it up to all of the panelists. Can you speak a bit to the value of outcomes-based financing? It's a question that we got in the chat, so I did want to have that addressed, but I'll open it up. So whoever would like to take that, please do.
I'll start maybe, and then any others can come in. Yes, so in terms of let's say debt swaps, there's different types that can be set, right? There's the input and there's the outcome based. Actually, many examples of debt swaps have been sort of based on the input. So for instance, I think the most the big example of the protection of the Galapagos, where debt was a swap. Like essentially the country had to commit that they would invest this money in the protection of that natural area, and in exchange the same amount would be removed from their their existing credit. However, it's not ideal, because it's for health, for instance, if you just said, oh, you need to allocate this to health, first, you don't know that this health money is actually well allocated, that it's reaching the front lines, that it's doing as much good as it should. And so this is where there are different mechanisms that you can think of, and it's a little bit of a complex discussion, but where if it's a long, right, you might be a long instrument. Maybe at the very beginning, you're looking more at trackings of outputs, but then once the country has put in place strong systems, and obviously there is a need to align, if you have, for instance, a debt swap, which is a combination between, and so could be a creditor, that would be, for instance, a country, or in some case you could consider, there's commercial debt swaps as well, but a philanthropic also coming in, that essentially after a few years, instead of just checking and monitoring that, oh, has the country done this with the health money, we're actually looking at, are they hitting the outcome goals? And this is where I was saying you might want to set a few different indicators that span several conditions. So for instance, nutrition right now is a primary concern for a lot of countries. Have improved a lot in immunization, right? But when you look at the nutrition outcomes, you're still seeing 30+ stunting rates. So having kids that are having those rates decrease, it's going to take the kind of cross-sector collaboration that Christian was talking about, but it's something where you can incentivize that. If you say to countries, okay, now we're putting more focus, that your debt will actually be waived, but under the condition that in a few more years, the percentage of kids stunted, which is going to be both assessed by surveys, administrative and coverage surveys, has actually gone down. So it's a little bit of a technical matter, and I wish I had more time to talk about it, but maybe if Kathleen or Christian, you want to come in, you can.
There's another question in the chat about public-private partnerships. The person says, worked well to finance healthcare and what to do differently to have it succeed. There's an untapped funding potential because governments and organizations often wait to be approached by the private sector. And I just wanted to respond to that question specifically. Like, I couldn't agree more. I think what has happened with the current financing structure is that NGOs, large NGOs, have crowded out, almost have had monopolies over entire markets, like sexual and reproductive health products, condoms and birth control pills, for example, and crowded out the private sector, the for-profit private sector. And that's not going to be really feasible anymore, just because there's just no more funding to do that. And so there's a real opportunity, because there's a whole infrastructure of a private sector that governments and communities can really rely on. But to do that, we need to improve governance again. And so we need to sort of make it attractive for these private sector companies and stakeholders to say, hey, this is an attractive idea for us to participate and to join this. It's not going to cost me a fortune to become a formal sort of pharmacy provider, for example. Administratively, make it less complicated. but it does require surveillance, it requires quality checks, it requires coordination between a public and a private sector. And so again, a sort of need to make that whole administrative and fiscal environment more attractive to private sectors to contribute. Yeah, I don't know if anybody else want to add to that.
Yeah, maybe I can quickly come in on that as well, just because I think that public-private partnerships, like in a place like Malawi, for example, have served like a really important role in expanding the access to healthcare. There's a big like Christian Health Association that provides 37% of all services in the country that the government has a public-private partnership with, and the focus is on primary healthcare. And I think being able to kind of like leverage on the existing infrastructure, the existing staff within an agreement that makes sense really allows for the government to be able to reach more people with like within the resource envelope that it has. So I think that's like one good example of how countries can also work with private sector to expand access to care for like vulnerable populations and those that like can't afford to go pay and access care at private facilities themselves.
All right, folks, I'm going to need to jump in. Aasit, do you want to just wrap it up?
No, I think this was great. I
Mhm.
think this was great. And, obviously this is a conversation that needs to continue. This is an ongoing kind of discussion and a reminder to everyone that we are a collective group to reach out to your peers, to reach out to your colleagues, to reach out to those who are on this panel, who are on this chat. We're going to get through this together, and we're going to work hard to see what the foreign aid landscape will become in the coming months and years. But Heather, I'll hand it off to you, and thanks again for the opportunity.
Absolutely. Well, thank you so much, Aasit and Kat and Christian and Soleine. I really appreciated all your thoughts and perspectives. I think it really provided some good illustrative like examples and understanding. Health financing can just feel very overwhelming and unclear. So I really appreciate the thought and effort that you put into both sharing what you're seeing now, as well as ideas and thoughts for what we need all to be considering for the months and year ahead to really think about what is it to be rebuilding the ecosystem through an equitable lens, and financing is going to be a really big part of it. So thank you again. Thanks to everyone who joined. Please continue to share your thoughts and ideas. Keep up on this topic, and wishing you a good rest of your day. So take care, everyone. Thanks again. Bye, folks.
Thank you.